Hello everyone. Today we are going to start with our first topic, that is temporomandibular joint disorder. As some of you have pointed that this particular topic is not covered till now in the final year. So we'll be starting with the first topic of temporomandibular joint disorder. I have broken up this particular topic. It's a huge topic which will be covering. The first module will be to understand what is temporomandibular joint. We need to understand its basic anatomy, the functioning of temporomandibular joint. We'll be looking at various etiologies which are responsible for this particular joint disorder, and we'll be covering up the classification of temporomandibular joint disorder. The second module will be we'll be taking up the various imaging modalities which are presently available for the assessment of temporomandibular joint disorder, and the third module will deal with the various types of temporomandibular joint disorder as per the classification in the module 1, and the respective treatment for that particular disorder of temporomandibular joint. And then in the same third module, we'll be covering some minor topics which you would have already covered in other subjects of the dentistry. So coming up to temporomandibular joint anatomy, we need to understand that head is the most complex structure in human body. Your particular head encases within itself the most complex organ, that is your cerebral cortex, that is your brain, and it provides different function. Head itself provides different function. You have got neurologic function, which is associated with what you see, what you hear, what you smell, what you taste. All these sensory organs are present within the head and they are interpreted there itself. The head also provides opening for a respiratory system, which is responsible for breathing, assessment of quality of air, um, uh, the demand of the intake and exhaling of air. It is also the opening for a digestive system, ingestion, deglutination, and it also provides initial digestion of the starch by the way of release of salivary amylase. It is also a center for communication, wherein we do the facial expression, the expression of facial expression, facial appearance, airway. It has also got a masticatory apparatus, which allows us to open the jaw, opening and closing of the jaw for the mechanical aspects of the speech. Then the most important, primarily why your temporomandibular joint is there, is because it is one of the component of your masticatory apparatus, and since this is the important aspect of your temporomandibular joint, your masticatory apparatus, if you look the entire skull, occupies the largest portion of the head. And central to this masticatory apparatus, it has been found that temporomandibular joint plays a very important role. Now, from developmental point of view, till now whatever studies have been done, it is noticed that temporomandibular joint is a very unique joint. It is the last joint in our body to develop. Majority of your joints develop at a early age, but the temporomandibular joint is the last joint in your body that is to develop. And in fact, it has been seen that this particular joint has a tendency to keep on changing its morphology throughout your life. Both the right and the left joint, they need to move together, so that's why this is also termed as diarthrodial joint. What I mean over here is you can move all the other joints of your body separately, like you can move your right elbow separately, independently, and you can move your left elbow separately. But this is not possible in temporomandibular joint. The right and the left both are connected with a single bone, that is your mandible, and both are dependent on each other for the movement. And the third point is this joint is partly hinge and partly gliding movement. I'll be showing a video of the functioning of temporomandibular joint. This particular terminology is Ginglymo. That is, you have two movements which are present in this particular joint. The hinge movement, that is rotation within an axis. This is partly, and the initial joint movement while opening the mouth. And the other part of the movement is a gliding motion, a sliding motion, wherein temporomandibular joint slides in front, slides downward in front. So you got two movements in one single joint, the hinge and the gliding movement. That's why it is called as Ginglymo. And hence the total in total this joint is called as Ginglymo diarthroidal joint. Okay, and from a dentist point of view, we need to know that it has been seen that the occlusion of a particular individual has got a major impact in the morphology and functioning of temporomandibular joint. And not just the occlusion, the individual teeth within this occlusion, they also dictate the functioning of this particular joint. And the last, it bears the entire load of mastication. The temporomandibular joint, it bears the load of mastication over there. Now, to understand the functioning of temporomandibular joint, we need to know what are the components of temporomandibular joint. The temporomandibular joint is basically made up of two articulating surfaces. One is your condyle, which is contributed by your mandible. The other one is a glenoid fossa, which is contributed by the skull. So, in between the condyle and the glenoid fossa, you have a disc which is called as articular disc, and you have fibrous capsule which encloses the entire temporomandibular joint, and you have the ligament system that restrains the movement of temporomandibular joint. The functioning of temporomandibular joint is also associated with the muscles of mastication. After all, they are the one which will guide the temporomandibular joint. The major muscles of mastication, they are in pairs. These are the masseter, the temporalis, the medial pterygoid, and the lateral pterygoid. Now, a very important part, we don't know why, but very important part over here, we need to understand that the three muscles, the masseter, temporalis, and the medial pterygoid, these are responsible for the closure of the joint. The primary function is the closure of the joint, that is the elevation of your mandible, and the muscle lateral pterygoid is the only joint which is responsible for opening of the opening of your mandible. Okay, so understand this. You have got three muscles: the masseter, temporalis, and medial pterygoid, which closes your jaw, and the only muscle, the lateral pterygoid muscle, which is responsible for opening of your jaw. Okay. Condyle, it forms the lower part of the joint. Condyle is the posterior most part of your superior and posterior most part of your mandible. Condyle is generally elliptical in shape. Variations are seen depending upon age, sex, person to person. Variation of condyle is seen. Mandibular fossa is the superior part of your temporomandibular joint. It is a hollow portion in temporal bone, and your condyle literally fits into the mandibular fossa. The entire joint, if we see, including the mandibular fossa, is an S shape, and there is an eminence which develops at the age of 6, and this particular eminence is it continues to develop till the second decade of your life. Now, what is the importance of eminence is, during wide opening, the condyle, it rotates around the hinge axis and it glides till the eminence. So, I have got a video which I'll be showing once again. We'll be discussing the entire thing. I just want to highlight over here is the eminence which is there. That is the maximum limit which is permitted for the condyle to go anteriorly, not beyond that. we'll see what will happen if condyle goes beyond this particular eminence. Okay, then there is a capsule which is lined with synovium. There is a synovial membrane. This entire joint from inside is lined by synovial membrane. The major function of synovial membrane is secretion is associated with the nutrition to avascular components of the condyle. It is associated with the collection of the metabolites of there. It is associated with lubrication. They release what is called as synovial fluid, and this particular fluid is very important in lubricating the temporomandibular joint. Okay, and the both the articulating surfaces, they are covered with fibro cartilage. We have hyaline cartilage, elastic cartilage, and fibro cartilage, three types. This is occupied with fibro cartilage. And coming to the articular disc, which is there, this articular disc, it occupies the middle portion of the joint cavity, and this articular disc, it is dividing the joint into a superior compartment and inferior compartment. A point to be noted over here is the superior and inferior compartment do not communicate with each other. They are totally separated by this articular disc. The disc is attached to the lateral and the medial poles of condyle. Now, this is very important. To understand this, I'm not able to show you pictorially, but just a very important aspect over here is there are two ligaments which are holding this disc very firmly. These ligaments are inserted, one on the medial side and one on the lateral side of the condyle. So, since they are ligaments, they are not stretchable. Your disc at any cost will not be able to go on the medial or the lateral side of the condyle. Okay. So, the point over here which is to be noted is, because of this particular attachment of the disc firmly on the medial and the lateral side, the disc is only permitted to have a rotational movement on the condyle. In other words, the disc can go front and the disc is allowed to go back, but the disc is never allowed to move on the sides of the condyle. So the disc can go on front and the disc can go on back. Looking at the finer details of the morphology of the disc is thinnest in the center and it thickens to form in the anterior and the posterior bands. So it is something like the shape of your biconcave shape, the shape of your RBC, and the center of the disc is thin and the periphery of the disc is thick. Point to be noted also that the disc is avascular and it has got little innervation. Avascular over here means it does not have any blood supply over there. So what does that implicate? That implicates that this disc totally relies on the nutrition which is derived from the synovial fluid. And a very important aspect which we tend to forget over here is any damage that happens to this particular disc, as it is avascular, it takes tremendous amount of time for repair of that particular disc. Okay, so any detrimental forces on the disc will take long time to recover. So that is why temporomandibular joint disorders, they are classified as chronic diseases, and they require a good amount of time for repairing themselves. Okay, and the second important aspect over here is it has got little innervation. Now this is a drawback over here. The drawback over here is whenever you have an injury, it is always accompanied by senses which are felt by your nervous system, that certain damage of this magnitude is happening to this particular region. So since the innervations are less in the disc, uh, it is very difficult to most of the patients, they don't feel the damage happening to the disc over a period of long time, and you have suddenly at one particular period temporomandibular joint disorders which start developing in them. We'll just have now pictorial what I exactly wanted to discuss with the anatomy over here. Now we need to see the first thing. It has got two bony components, the condylar head, this is the condylar surface, and this is your mandibular fossa or the glenoid fossa. Okay, so this is a part of mandible and this is the part of your temporal bone. Okay, and both the surfaces are very smooth. The condylar surfaces is a part of the lower compartment and your mandibular fossa is of the upper compartment. Now this particular mandible fossa is followed by one slope, and this particular bony eminence, this is called as articular eminence. The joint is separated by a disc which is called as articular disc, and as discussed previously, the articular disc is having the periphery which is thick, that is the back side, and the front side which is thick, and you have got the center portion which is thin. Now, in this particular picture you can see that the articular disc, it is thin in the center and it has got thickness at the periphery. Okay, and your articular disc is attached to a certain amount of fibers which is called as posterior attachment. We will be covering this next, and from front it is attached to a part of your lateral pterygoid muscle over here. Now these two diagram over here, these two picture over here, it is when you are seeing a person from the side, and this is your lateral view in other words, and this is your frontal view, PA view. That means you are seeing the patient from the front over here. Now here I wanted to tell that your articular disc, if you see from the PA view or from the front side, these are the two poles, a lateral pole and you have got a medial pole, and your articular disc is firmly adherent to these two poles. That means your disc cannot move laterally, cannot move medially. But when you look over here, your disc can move front, that is your anteriorly, and your disc can also move back, that is your posteriorly. Okay, so this is the basic components of your temporomandibular joint. Then you have got the fibrous capsule. You can see the fibrous capsule. When the joint is closed, the capsule is relaxed, and when the joint is stretched, the capsule is extended and it is still intact over here. Ligament is very essential because it does not allow the temporomandibular joint to shift laterally, especially when there are heavy forces which have tendency, such as traumatic forces, which have tendency to dislocate the temporomandibular joint laterally. So the lateral ligament ensures that, or it double ensures the restricted movements of your temporomandibular joint. I'm sorry, I'm not able to activate this video. Yeah, okay. So this is
This is
your
a normal temporomandibular
temporomandibular
joint.
joint
The disc is
over
biconcave
here.
and it's
And
located in a superior
first, let us
position.
see the functioning of a normal joint.
The central thin part of the
Normal
disc
components.
is
This is your
consistently
condyle.
lying in
This is your
between the
mandibular
condyle and tubercle.
fossa, the glenoid fossa. This is your
During
articular
opening, there is
slope, and this
rotation
is
in the
your
lower
articular
compartment
eminence.
and more
Okay,
translation
so
in the upper compartment.
usually your condyle, the maximum limit is up till the articular eminence, which is there. The other component of temporomandibular joint, which is very important, this is your articular disc. So articular disc, as I have discussed over here,
This
is
is a normal
having
temporomandibular
a
joint. The
thickness
disc
which
is
is in the
biconcave
posterior
and
and
it's
in the
located in the
anterior,
superior
and
position.
between of the
The
articular disc,
central thin
the center
part
of
of a
the articular
disc
disc
is
is a very
consistently
thin
lying in
tissue
between
which is present.
the condyle and
The
tubular
articular
tube.
disc is attached in the
During
posterior
opening,
by a
there
group
is
of
rotation in the
posterior
lower
attachment.
compartment
This
and
is a
more of
complex which is made up
translation
of
in the
fat,
upper
elastic,
compartment.
cartilage, ligaments over there. If you see very carefully the functioning of this particular posterior attachment, I'll pause over here. It restricts the anterior extent of your extent by which your articular disc can go in front. So this is the role of your posterior attachment over here. Okay, and from the front, if you see, you have your lateral pterygoid muscle, which gives a part of insertion into your um, articular disc, and the remaining major insertion, it is joined to the neck of the condyle, and that particular place of insertion is called as pterygoid fovea. Okay, so once again, let us see, and a very important aspect why I have included this video to understand the temporomandibular joint disorder is the position of the articular disc. Just examine, I'll play this video once again, and just you see that the articular disc, if you see very carefully, this particular thinnest portion will always be present over the condyle. This is not going to change its position over the condyle. Let me remind you once again that this articular disc is not attached to the condyle from here. It is attached from here and it is attached from here, but it is not attached from here. Okay, it is dividing into superior compartment and your inferior compartment. But a good functioning temporomandibular joint, the articular disc is always maintaining its position over the condyle. So just have a look of this video once again.
This
Just
is a
see,
normal
the articular
temporomandibular
disc, the
joint.
thinnest portion, is
The disc is
always
biconcave
over the
and it's
condyle.
located in a superior position.
Okay, so it's a very
The
nice
central thin part of a
video
disc
which
is
shows
consistently
actual
lying in
functioning of
between
your
the
temporomandibular
condyle and
joint. Okay, so the last part of temporomandibular joint, these are the ligaments of temporomandibular joint. Ligaments are the ones which attach bone to bone. Okay, so these ligaments of temporomandibular joint, they are the capsular ligament one, which makes the entire temporomandibular joint, gives a compartment type of effect. Then you have the lateral ligament. This is the very important ligament of temporomandibular joint. As I discussed, this particular ligament does not allow the lateral translation of temporomandibular joint. Then you have got the spinomandibular ligament. Sorry, the spinomandibular ligament. So it from sphenoid till the mandible, there is a ligament, that is your spinomandibular. These are called as restriction ligaments. And then you have got the stylomandibular ligament, which is attached from the styloid process till the angle of the mandible. So say if a person is opening the jaw, this particular ligament is responsible for the maximum extent your mandible can go. Assuming these are something like gode ki lagam, if you just assume that this particular ligament is ruptured or elongated, your mandible has a tendency to go in front of articular eminence. Okay, so you can have an open mouth, open lock over there if this particular ligament is. Just assume that this is just a restricted ligament, the maximum extent mandible is permitted to open. Now, the muscles of mastication, I'll finish this very fast. You people know this. You have muscles of mastication and you have got accessory muscles. I am just discussing the muscles of mastication. The first one is your masseter muscle, which is present on the lateral aspect of your mandible. It is inserted from, it has got three layers of fibers over there, and it is inserted from the zygomatic bone and your arch, zygomatic arch, and its insertion is at the angle of the mandible. Okay. And then the other muscle is your medial pterygoid muscle. The medial pterygoid muscle arises from the medial aspect of the lateral pterygoid plate and is inserted on the medial aspect of the angle of the mandible. You have got the temporalized muscle. This is a fan shape of muscle which arises from the nuchal lines of the lateral aspect of your skull, and they all are then inserted into the coronoid process, and a certain amount of fibers are inserted into the anterior border of your ramus of the mandible. The last and the very important muscle is your lateral pterygoid muscle. It has got two heads, the superior head and your inferior head. Superior head arises from the crest of sphenoid, and certain part also has origin from the lateral aspect of lateral pterygoid plate, and then it has got a major portion, that is the inferior belly, inferior part of your lateral pterygoid, which arises from the lateral aspect of lateral pterygoid plate and is inserted into the pterygoid fovea. Okay, now a part of this particular muscle is the superior head is also giving insertion to your articular disc. Okay, so anatomy of clinical interest, just I am going very fast. You need to jaw jerk reflex. Okay, something like your knee jerk reflex. It is a jaw jerk there is a jaw jerk reflex, there is a stretch, it is a stretch reflex. I can just give an example of jaw opening reflex. Whenever you are, it's just a reflex which is present because of sensory neurons uh, in your muscles of mastication. These are mechanoreceptors or nociceptors which are there. Say if you are eating a particular food item, something like a rice, and where your brain is assuming that it is a very soft food, and when you are chewing this and suddenly you have a small pebble that comes into the way, and the moment this pebble of a different hardness or a consistency is felt by your teeth, immediately your jaw, they open out. So this is your jaw opening reflex. It's just a common example which I'm trying to give. And then you have the rest positions. These are very important: centric flexion and centric occlusion, which you have already dealt in your prosthodontic. Then you have the range of mandibular movements, how much in front the mandible is going, how much in sides the mandible is allowed to go, how much the maximum opening of mandible. These are the various ranges of your mandibular movement. Okay, and then you have a categorization of disc displacements, how much in front the disc is going, how much in front how much backward the disc. Remember, there are no displacement of disc which happens side to side. Then anterior disc displacement, joint noises which are there. Some textbooks they write crepitus. That is something like your dry leaf when you crush in your palm with your fingers, and then you have the clicking sounds which are there, or popping sounds which are there. Okay, so sometimes there might be certain nerve, auriculotemporal nerve, which gets compressed, maybe probably because of decreased vertical dimension and variation in course. This could be one of the reason why Costin syndrome, at one particular time Costin syndrome was very well known, especially in prosthodontics. So Costin syndrome could give rise to features of Costin syndrome. Okay, so we have seen that individual teeth in both upper and lower arch, they are directly or indirectly associated with the functioning of temporomandibular joint. So we need to understand the occlusal stability, and we need to understand physiological occlusion. All these are important during the time of treatment of temporomandibular joint. So now we are going to see the etiology of temporomandibular joint. These are mainly because of parafunctional habits. That is the first categorization of etiology, parafunctional habits. Something like nocturnal bruxism, tooth clenching, lip or cheek biting. Now understand over here, bruxism is grinding of your teeth. Um, um, it is more associated with stress, something associated with certain types of psychological disorder. So nocturnal bruxism, nocturnal means nighttime bruxism. Now there are different ways by which your body releases stress outside. Some of you get headache, some of you might have loose motions, some of you and you have lack of sleep. One of the nail biting, lip biting, all these are parafunctional habits. Now, nocturnal bruxism is also a type of parafunctional habit over here. What happens during nocturnal bruxism and tooth clenching? These they are not the normal function of temporomandibular joint. The temporomandibular joint throughout the day, it is working for you, especially while eating food, while you are communicating, while you are talking, whatever it is. Whenever you are opening mouth, your temporomandibular joint is functioning. Now, night is one particular time when temporomandibular joint needs rest, and there are certain damages that have happened during the functioning of the temporomandibular joint at the daytime, and nighttime is the time when temporomandibular joint requires rest. So if you are using temporomandibular joint by the way of nocturnal bruxism even at night time, so this repair thing which needs to be done by temporomandibular joint is not happening. In a similar manner, tooth clenching is holding the teeth to the together at occlusion and giving a force. See, bruxism is rubbing the teeth with one another, whereas tooth clenching is not rubbing your teeth. It is just holding the teeth in your occlusal and giving huge amount of forces. Okay. So this particular thing you can observe in certain type of profession. Might be some of you might also have this particular tooth clenching habit, especially when you are immensely stressed and you are doing some job which requires a lot of concentration. Say for example, IT professionals, when they are loaded with a huge amount of project, you can see that sitting in front of the computer screen, and they will be having this particular clenching habit. Okay. Some other profession where you require very good amount of concentration, you have the clenching habit over there. Lip and cheek biting, they are also associated with parafunctional habits, extra work that your temporomandibular joint have to do. So this is the one of the most common cause for temporomandibular joint that we need to look for. The second important aspect is emotional distress. This is what I was discussing, the various ways by which your body uh, tries to de-stress itself. So emotional stresses are there. So you need to uh, probably you need to ask your patient and take history whether he is suffering from any type of emotional distress or some psychological disorder which are having association with temporomandibular joint. Acute trauma from blows or impact. This is the third categorization, third major cause, major etiology of temporomandibular joint. Any form of trauma, fall down during the childhood, can be a fall down during the childhood. It can be a trauma, probably a road traffic accident, or domestic violence, physical assault, some sort of blow or impact that your mandible has received. Now it looks very minor or very not that important aspect to ask in history, but actually it can be a trauma which is of childhood time, and that can be related to your existing temporomandibular joint disorder. So never miss taking history of acute trauma from blows or impacts that your mandible has received, which could be a reason for temporomandibular joint disorder. Sorry. Trauma from hyperextension, dental procedures, very important. Do not expect your patient to open for a long time for your dental procedures. Always try to keep a short procedure over there. So hyperextension over a long period of time can exacerbate temporomandibular joint disorder. Oral intubation from general anesthesia. Now, you have an intubation which can be from your nose, and you have an intubation which is from your mouth. So, those general anesthesia procedures where the intubation is being done from the mouth. So, usually, when the patient is already anesthetized, hyperflexation of joint occurs because of the intubation over there, and hyperextension of this particular joint can once again lead to temporomandibular joint disorders. Yawning uncontrolled sometimes, as you people will be doing now, uncontrolled yawning, that is also over a period of time it causes stretching of the ligaments, hyperextension of joint, and hyperextension associated with cervical trauma. What do I mean by this? Presently, if you have seen our previous generation, our parents have always been telling us to sit straight while studying, keep the back straight and study. But if you see generally over there, many of us, we have a stooping posture, and we try to keep our chin in front, and whenever we are studying or whenever we are watching television or something like that. So this particular position, it causes a hyperextension of the jaw, and that is also responsible for temporomandibular joint disorders. Okay, and instability of maxillomandibular relationship and laxity of joint are the other reasons why you can have temporomandibular joint disorder. Comorbidity to other, that is rheumatic or musculoskeletal disorders, means here comorbidity over here means that the joint disorder can be associated with rheumatic disease, rheumatoid arthritis or something like that, or some musculoskeletal disorder. You don't have the problem in joint per se, but muscles of mastication are having some disorder, because of which the temporomandibular joint is also suffering. And overall, if the patient is having poor general health and an unhealthy lifestyle, they also contribute to temporomandibular joint disorder. Now, if you look at all these various etiology which we have discussed, it is very clearly understood that no one particular etiology is solely responsible for temporomandibular joint disorder. It are the various types of, it is a group of the enlisted etiology which are responsible for causation of temporomandibular joint disorder. Okay, so I'll just uh, take a pause over here. You please understand epidemiology over here. I'll give only 1 minute pause over here. Right. So, what this particular slide deals over here is that 65 to 85% they experience some symptoms of temporomandibular joint in their life. That means, if I take a population of 100 individuals, Among them, 65 to 85% will have some symptom of temporomandibular joint disorder at least once in their lifetime. Okay. Among these 65 to 85, approximately 12% will have a prolonged pain. See, time and again I am stressing that temporomandibular joint disorders are more classified as chronic pain related. So prolonged pain will be there. Who? 12%. 12% of what? 12% of 65 to 85%. And out of this 12%, 5 or 7% will have discomfort severe enough that they might turn up to you for some sort of treatment or some sort of relief from their existing temporomandibular joint. So this is your epidemiology over here. So these are various types of classification. Now muscle disorders, you can have muscle tension, you can have muscle spasm, you can have muscle inflammation, you have the myofascial pain dysfunction syndrome. This is very important, we need to read about this. This is asked as a 5-mark question, can be a 10-mark question. Then you have fibrosis and contraction, you have atrophy, you have hypertrophy, you have muscle tears and laceration, you have trismus, you have fibromyalgia, and you have neoplasm. Since I am not going to cover all these things, I'll just tell you what exactly are these. Muscle tension is when the unnecessarily excess amount of muscle fibers are getting contracted. You have the spasm over there. These two are self-explanatory over here. Muscle inflammation because of viral or some other diseases, or because of trauma, or because of any reason, any traumatic reason, you have the inflammation of muscles, you have restricted movement, and thus you are classified under temporomandibular joint disorders. Okay, this we are going to read myofascial pain dysfunction syndrome. Fibrosis and contracture are seen after a particular damage to the muscle has happened. These two phenomena are associated with healing of muscle. Okay, so whenever there is a laceration or there is some sort of damage to the muscle of mastication, they heal either by fibrosis or contracture. So a healed tissue, either in the form of fibrosis or contracture, since it is not composed of muscle, it loses the property of muscle, and then you have restricted movements of the muscles. Atrophy is when a particular muscle is not functioning, and over a period of time it becomes smaller in size, it becomes atrophy. Then you have hypertrophy of the muscle. Hypertrophy is a particular muscle which has been used excessively. Looking at the demand of that, the hypertrophy, there is increase in size of the muscle. Muscle tears and lacerations are associated with trauma. Then you have the trismus. You have huge list of reasons for the trismus of muscles of mastication. Fibromyalgia, it is a pain associated with fibrosis of the muscle. That's why it is called as fibromyalgia. Myalgia is pain associated with muscle. And you have got neoplasms, various types of neoplasms of your muscles that are hampering the temporomandibular joint. Now, the other classification of temporomandibular joint disorder is arthrogenous, that is the joint per se as disorders which are there. You have the internal dearrangement, you have deviation in form. Deviation in form is deviation in form of the function over here. So this is frictional disc incoordination. So articular disc, because of friction, is not able to move smoothly front and back. It gets incoordinated. So that is why it is classified as frictional disc incoordination. Articular surface defects. It is not smooth. There are some roughness present over there. Certain diseases are associated with that. So articular surface defects. You have got disc thinning and perforation. Excessive use of the articular disc. Already it is thin in the center portion, it becomes thinner, and at one particular time there is a hole, and the upper and the lower joint compartments now start communicating. So that is why it is classified as disc thinning or disc perforation. Disc displacement, you have got partial disc displacement in that. You have got disc displacement with reduction, which can be either partial or it can be complete. Then you have disc displacement with intermittent locking, disc displacement without reduction. So your anterior disc displacement, posterior disc displacement, all are classified under this etiology or under this classification. You have displacement of disc and condyle complex, which leads to either subluxation or the dislocation over there. Then inflammation of temporomandibular joint. Joint is inflammation of joint is called as arthritis. So don't confuse with arteritis. Arteritis is inflammation of arteries. This is inflammation of joint. You have got the non-inflammatory arthritis, which is called as arthrosis, osteoarthrosis. This is age-related phenomenon. Most of the geriatric population, they suffer from this disease. Inflammatory arthritis, in that you have rheumatoid arthritis, juvenile rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and lupus erythematosus. So majority of these diseases are autoimmune associated diseases. They primarily affect the other large joints of your body, and occasionally your temporomandibular joint can also be uh, uh, affected by these diseases. Then you have the infectious arthritis, that is inflammation because of an infection over here. You can have a direct extension over here. Say for example, there is a middle ear infection, and since your temporomandibular joint is very near to the ear, this infection, it spreads to your temporomandibular joint and it causes a direct extension and infectious arthritis. It can be systemic infection. Systemic infection, like you have gonorrhea, which is a venereal disease, a sexual disease, and then you can have these gonorrhea, the bacteria traveling via bloodstream and then reaching your joint and causing your gonorrheal arthritis. These are two examples. Source of infection near the joint, direct extension, and source of infection which is away, indirect extension. So infectious arthritis because of systemic infection. You got metabolic diseases, gout and chondrocalcinosis. On a majority, these two are seen associated with other larger joints of the body. Yes, terminal phalanges and your metatarsals, they are very commonly associated with gout. Uh, Sometimes you can have your temporomandibular joint also also involved with gouty arthritis. You have got inflammation of capsule, inflammation of synovial membrane, so capsulitis and synovitis. Damage to the posterior attachment of the disc, it is called as retrodiscitis. Trauma directly or indirectly received by temporomandibular joint leading to fracture of temporomandibular joint. You can have ankylosis, which can be fibrous, which is usually classified as pseudoankylosis, and you can have attachment of condyle and the mandibular fossa bone, temporal bone, which is called as bony ankylosis or true ankylosis. Developmental disturbances of temporomandibular joint. These are your condylar hyperplasia, condylar hypoplasia, condylar aplasia, and you can have neoplasias. There is nothing called neoplasia of temporomandibular joint. It is the components of temporomandibular joint. Neoplasia of the bone like osteoma, osteosarcoma, osteoblastoma. You can have neoplasia of the cartilage of those of the temporomandibular joint, chondroma, chondrosarcoma, all those things. So these are some of the diseases which have been classified under temporomandibular joint disorders. Well, I'll be stopping my discussion over here, the module 1 of temporomandibular joint disorders. What I now want you all people to do is, below your screen you will be seeing a small area where you can type in the comments pertaining to today's lecture. This is my first lecture. I'm not well versed with online teaching like this. Anyhow, I have given a sincere attempt over here. You can put down your remarks over there. You can give from 0 to 10 my teaching with this particular modality. I also want you to type in your name and send in the remark. This will be used as a mode of attendance. Okay, I'll give you another 5 minutes. Uh, another 5 minutes for typing and sending me the remarks, and beyond that, I will not allow any more remarks, and only during this period of time your attendance will be accepted. Take care, stay safe, be in your house. Disturbances